So nothing is permanent. What we learned from the last lecture, people are there to change even when they are doing good. We are searching for better and best. So what is this intelligence and intelligence going on? So it is artificial intelligence that we are making computer intelligent by giving data, and probably computer is going to make us intelligent or probably better, and that is what going to give a better result for us in our future. So is the artificial intelligence and machine learning is same? Previously when I started robotics, when I started going into this part, I was thinking yes, artificial intelligence and machine learning is same. But when we go deeper and deeper, artificial learning, machine learning, or artificial intelligence, machine learning, and there is another subset called as deep learning that I was again confused. So it is all the database which is getting created. The artificial learning is a bigger subset. Machine learning is a smaller subset of artificial learning where they tackle with a smaller problem, more precise data and more precise things. And the deep learning is solving the problem of artificial learning and machine learning. And this data, when we are going to create, this data is probably going to use in the future to assess our results, and it is probably going to give us subsets of each thing. What is pre-operative alignment? What was post-operative alignment? What was the stay of the patient? How much day stay in hospital stay is reduced? And a lot of things will be decided in future with this data. So it is what we say, what we will get, what we will give. And these are the applications of artificial intelligence in the arthroplasty society or arthroplasty fraternity, probably depending on imaging, change into the implant design. Probably we will be giving data, and there will be a future where you just put the X-ray and an application that will give you the size of implant, make of implant, where it was done, post-operative follow-ups, rehabilitation based on what patient is doing and what patient is not doing. Probably there are some intelligent implant which are coming into market, which will tell us what is your patient is doing right now. So in last 2 days we were there in Mumbai, and probably we are at very basic phase where we do not know whether it is really helpful for us. The robotics in joint replacement, whether really it is helpful or not helpful. There are a lot of data which is coming up, but it is still not validated, it is still not accurate, and we are still at a pivotal point to accept or to defeat the use of artificial intelligence and robots in arthroplasty. So we had this consensus meeting, and probably it will be a long consensus meeting that we want to come to consensus regarding some basic points. And I happen to be a lucky person to have the same point, that is there any sufficient evidence for a new generation surgeons to learn robotics. So it is the consensus meeting is for hypothetical questions and find out the articles and come to the conclusion whether is there a sufficient data or not sufficient data. But what are the hypothetical questions is probably what we have got in last 2 lectures. That learning curve for robotics is a hypothetical. So what is the learning curve, and what after how many cases we will probably learn the robotic things? Is it so? Now we know that there are 2 or 3 types of two types of robo, that is image based and imageless. Is it okay if I have image less robo which will be doing better, or image based robo will do better? Do we need the basic understanding? What was the nice question which came up on the last talk by Rajkumar sir, that we need the basic understanding of conventional TKR before robotic TKR. Do we agree that there is a learning curve for implant positioning? It's okay that we can cut with the robo, we can cut with the saw. The robo is cutting with the saw. But are we going to position the implant properly? What is happening when we are doing it with the conventional robo and without with the conventional and with the robotic TKR? Are those patients are satisfied? Are the patient related outcomes and patients are satisfied after doing robotic TKR? And is this learning will affect? So if I'm going to learn my robotic TKR in say 70 cases, what will happen to my first 70 cases? Am I just playing with them? Am I just playing with their future? So is there any data that whether learning of robotics will affect your patient related outcomes or not? And do we believe that there should be a standardized protocol or standardized training program with eligibility of doing some n number of cases conventionally, get mastery into that, and then go to robotics? So we identified 5 papers. Out of that, 2 papers were level 2 studies, 2 papers were level 3 studies, and one systematic review of literature. And there was no article on who should get started with robotics. So I'm just going to present these 5 papers in a short. So this is the robotic arm assisted total knee arthroplasty has learning curve of 7 cases for integration into your surgical workflow. And what they have, it is from level 2 study, and they say it is a 7 cases. You need at least 7 to 9 cases where you come from the phase 1 to phase 2. The phase 1 is learning phase, and phase 2 is a proficiency phase where you decrease your timing of robotic surgery. So they had 60 conventional cheek based cases and 60 robotic cases, and it is done by a single surgeon. What they observed is operative time, and they also observed the stress level of people, surgeon, assistant surgeon, nurses, and theatre assistants when the case of robotic TKR is there. And they also assess the accuracy of implant positioning, limb alignment, and complication within the first 30 days of surgery. So what they concluded in their paper is the robotic TKA took more time than the conventional TKA, and there was heightened anxiety of people when there was a robotic TKA. But there is no learning curve for the implant positioning, and there was no extra complication in first 30 days for robotic patients. This is the second study which studied in the same way. It is a different type of robo, a think robo, which is done in US. It is an open platform robo, and it is a level 2 study. And again, in that case, it is a multi-center study where they have studied the operation time, which they have segregated into the surgeon dependent and surgeon independent time. And they again assess the learning curve and PROMs. So what they found is the learning curve for TKR, being the multi-center and multi-surgeon study, it is around 10 to 12 cases. And there was no learning curve for implant positioning. So from day 1 or the first case, we can position our implant in the proper way, and the post-op alignment will be better. So the third paper, what we come to know is about imageless. So the papers were image based and imageless, so it's a mix of paper. And the imageless robotic had piece assisted, that is CORI, the learning curve analysis and surgical time and its alignment. So more or less learning curve and implant positioning and post-op alignment was the observation values for everything. And they also concluded that the learning curve is around 11 cases for handheld imageless robotics. And there was no learning curve again for positioning and joint alignment post-operatively. So the last paper is a systematic review of literature where they find out around 647 articles, and out of that they came down to 15 articles which showed more or less around learning curve for robotics TKR is around say 10 to 15 number of cases. That is what our hypothesis in consensus group also, and there was no implant related complication right from the day 1. So the application of this thing is that probably you might have to learn your first 50 robotic cases to 100 cases with the surgeon who is doing robotic or who is trained into robotics, and the anxiety and the appreciation of going bad into implant positioning and probably the post-operative application is still not there even when we are starting our robotics. So this is what from my side. Thank you.
Thanks, Chandrasekhar, for that brief to our literature. Anything, Rajkumar? What's the learning curve? How many cases? So, what the literature says, no? Average learning curve is 10 cases.
But it is not a fixed number.
It's
It
not a
has to
fixed
be.
number.
It has to be from surgeon to surgeon, individual to individual, and how quickly they are able to grasp the points. For that, again, the same point will be how good you are with your basics. That's all.
Kiran, doctor. Yes. So, Kiran, person can talk about alignments.
Good evening. I'm very sorry to keep you all guys waiting. Our flight got delayed from Mumbai. So I would like to thank Shivkumar sir for inviting me. So I will try and simplify alignment. So much of alignment thing is happening nowadays, especially in the setting of robotics. So we need to know whether it is to push robotics or there is some sense to this particular philosophies. So we will look at the principles and philosophy of functional alignment with robotics. Functional alignment, how to execute it using a robot, and discuss some of the common scenarios of virtual gap balancing and functional alignment with the mechanical alignment start point and kinematic alignment start point. So what is the difference between these two? Now if you look at these athletes who are football players, they are some of the best performing athletes in the world, and we can see that the knee alignment is not neutral in all of them. So to assume that everybody should get a 0-degree alignment in itself is probably a flawed concept, because although this particular knee, some of them are in varus, some are in valgus, they are still functioning very well to optimum potential. So to just extrapolate and say that the pre-arthritic alignment will lead to arthritis probably may not be true. Because they are really functioning well with that particular alignment. When we look at the anatomy of knee kinematics, typically because of the asymmetric shape of the femoral condyles on the medial and lateral side and the tibial condyle on the medial and lateral side, you tend to have what is called as a medial conformity. On the top right, you can see an MR film in deep flexion. You can see how the medial condyle doesn't translate too much. The medial meniscus is relatively well attached to the MCL and it creates a sort of a ball and socket on the medial side. If you look at the lateral side, the lateral meniscus is mobile, and in deep flexion you can see that the meniscus has actually subluxated out. And this is what leads to deep flexion, where the asymmetric nature causes external rotation of femur in flexion and the differing stiffness of the medial and lateral compartments make sure that the femur externally rotates and then the lateral meniscus slides off to allow for deep flexion. And this is guided in a large way because of the function of the two collateral and the ACL and PCL in what was believed to be a 4-bar linkage concept. So the idea is this. But we all know that TKR is a compromise. You are already removing both menisci. You are removing the ACL. If at all you want to retain the PCL, it's okay. Some bicruciate retaining designs are there. So therefore, to expect that the normal knee kinematics will be replicated by a TKR just by making changes to the bone cuts is a little bit presumptuous. I don't think it is possible. You still are doing some sort of a compromise. Now, what has driven this entire thought process behind different alignment philosophies is this landmark paper by Johann Bellemans. And this award-winning paper showed that neutral mechanical alignment may not be normal for all patients. 32% of normal men and 17% of women have got a constitutional varus mechanical axis alignment more than 3 degrees. That is traditionally considered to be an outlier, because looking at plus or minus 3 degrees as a good landmark for our TKR surgeries, which is the so-called adjusted mechanical alignment. And we found that if it is plus or minus 3, then the survivorship is good. That itself is based on a flawed paper by Merrill Ritter, who looked at short leg radiographs and then they said that 3-degree varus, 3-degree varus will be good. So we need to still consider all these things before we make our conclusions. Now, a lot of these people talk about Bob Bone's paper on patient satisfaction rate around 82 to 89%. And this again was a much quoted but again much flawed paper. So the dissatisfaction rate itself was related to how the patient was. It was not related to, some of them probably were not indications for surgery in itself, so they would be dissatisfied with surgery. So this 20% again is not a reliable thing, but this is quoted by a lot of robotic companies and also the robotic surgeons. I am also one of them, to convince people to buy a robot, which probably is inappropriate. I don't think it's the appropriate way of going about things. Now, if you look at these alignment options for TKR, it's a very good paper by Sebastian Parrott. These are all the things which are available. So you have this, what we call as the constitutional alignment with varus here, and that is replicated by unicompartmental knee arthroplasty, which is just a bone removing procedure. You don't do anything. ACL, PCL are intact, collaterals are intact, and it functions. Then we have the kinematic alignment philosophy, which just resurfaces the femur and tibia, and there is no soft tissue release done. So it will restore the knee to pre-arthritic alignment. So that is kinematic alignment. Now there are these restricted or hybrid alignment techniques like the restricted kinematic alignment, inverse kinematic alignment, adjusted mechanical alignment, which function within boundaries on the coronal side. That is what amount of varus or valgus you can give to the femur and tibia respectively. And the boundaries can be narrow as in adjusted mechanical alignment, where you have 3 degrees of play for the varus valgus, and it can be wide as in the restricted kinematic philosophies and some of the functional alignment philosophies. But traditionally, the John Insull method of mechanical alignment, where you are cutting perpendicular to the mechanical axis on both tibia and femur and balancing the knee through soft tissue releases, or cutting at 3-degree valgus on the femur and 3-degree varus on the tibia, as described by Hunger for anatomic alignment, again doing soft tissue releases to balance the trapezoidal gap, was the gold standard for a long period of time, and I think still is the gold standard. If you look at mechanical alignment, still is the gold standard. Now, what do we have? So we all know about mechanical alignment. So what are the options we have? We have the kinematic alignment, where we are taking out just adequate amount of bone from the distal, anterior and posterior femur equivalent to the thickness of the femoral component. So you are just resurfacing using a single radius femoral component. And again, tibia you are resurfacing. You are taking out the equivalent of tibia, which is equivalent to the thickness of the tibial base plate and the polyathlete. So in effect, you are putting the knee where it is, and you are restoring the pre-arthritic alignment. Now the challenge is, how will you calibrate pre-arthritic alignment in all patients, especially those with severe deformity. So that is the challenge with kinematic alignment. Now restricted kinematic alignment is there. I will go a little bit about this. And there is inverse kinematic alignment. So all kinematic alignments, femur is constant. So femur is not changed. All changes are made on the tibia to balance the knee. In inverse kinematic alignment, the tibia is constant. So you will do an anatomic tibial cut and put in a spreader, gap balancer in extension and flexion, and make appropriate changes on the femur to make the knee balanced in extension and flexion. So that is inverse kinematic alignment. And finally, you have the functional alignment, which can be narrow or wide boundary based, and we will see what all these are. So, I was talking about kinematic alignment. How would you calibrate the pre-arthritic alignment in deformities like this, which are very common in our part of the world? So, it's very difficult to calibrate the kinematic alignment in these cases, and it is not desirable. So, if somebody is talking about kinematic alignment in deformity, we must take it with a pinch of salt, because it's come from the West, where the knees are almost normal. There will be anteromedial arthritis, most of them, and then they are just doing a resurfacing procedure. So we should not use this terminology lightly. So what Vendetovi et al. Found was that 50% of the knees had a neutral HKA with LDFA 3-degree valgus and NPTA 3-degree varus, and these were amenable to kinematic alignment because it will work like an adjusted mechanical or a anatomic alignment to start with. So that is an accepted method. In their study in Canadian population, and we have looked at Indian patients, and the Indian patients are too much more varus than as compared to this particular data which has come out. Around 50% were not amenable because they are outliers. They are having more than 3 degrees of varus valgus alignment. So it's not desirable to recreate this pathologic anatomy, which could have contributed to the premature wear in some of these. So if you look at dysplastic hip, when you try and recreate dysplastic anatomy, that will fail fast because it's already excessively anteverted, it's more vertical, uncovered, so you don't want to create that anatomy. So he said we should have some boundaries to what we can accept and what we cannot accept. And that is where the restricted kinematic alignment came in, where they drew coronal plane boundaries of 5 degrees and overall mechanical axis boundary of 3 degrees. So this is restricted kinematic alignment. Now this is again another paper which has looked at the coronal plane alignment of the knee, looking at different joint line obliquities, neutral joint line, apex distal joint line and apex proximal. And this paper from Magdesi's group, you must read, all of the young surgeons, to understand this thing. And they found that restricted surgery restored balance more efficiently than mechanical alignment in each CPAC type. So they were looking at the coronal plane alignment, looking at joint line obliquity, looking at the anatomic HK, that is the difference between medial proximal tibial angle and the lateral distal femoral angle. So if you subtract this from that, if you get a minus value or a plus value, it will be varus or valgus. 0 plus or minus 2 is considered to be neutral. So that is what is the CPAC classification. So this is what they did. They found that if the joint line obliquity was less than 177, it was an apex distal. It is apex neutral. And if it is more than 183, it's an apex proximal joint line. And most of our patients are apex distal joint lines, with the joint line having LDFA being in varus or neutral or valgus, and MPTA being in definitely in varus. That is what is our native joint line. And when they calculated the arithmetic hip knee angle, this is not mechanical axis alignment. This is the subtraction of MPTA and LDFA. So it will give you what is the pre-arthritic alignment. And they found that plus or minus 2 is neutral, minus 2 or more is varus, and plus 2 or more is valgus. So each particular patient, so a single varus deformity can have a different type of a CPAC phenotype. So it could be apex neutral or apex distal or apex proximal. Overall alignment could be varus, valgus or neutral. So it is much more complicated than we think. And we also don't take into account the sagittal plane alignment and the rotational plane alignment of the knee. So we do not know what is S-pack which is normal, what is the R-pack which is normal. So whether if you just look at C-pack, whether it be adequate or not, we don't know. But this paper again has this thing. So we are left with these 3 things which is driving the whole alignment philosophy. What is the morphology of the bone? So what is the LDFA, what is the MPTA, what is the native AHKA and all these things, tibial slope, how the sagittal femur places. You look at the soft tissue tension, we all know that the laxities are independently different in different patients. Varus and valgus, with an overall alignment boundary of plus or minus 3. So if you cut the tibia in 5 degree varus, you will have to cut the femur in 2 degree valgus. There is no way. You cannot cut both in varus. Because the overall boundary is plus or minus 3. For functional alignment, as described by Faris Haddad, he said, okay, I will take 6 degrees of boundary. I will not have 3 degrees. I will keep 6 degree varus to 3 degree valgus. And I can make changes both on tibia and femur. So I will cut tibia in 3 degree varus, 2 degree varus over femur. So these are all the alignment spectrums. So just to summarize, what is the alignment strategy? For kinematic alignment, the boundaries are unrestricted. It is determined by whatever is the native femoral morphology. The laxity pattern restores native laxity. There is no soft tissue release. Femur is constant. All adjustments are made on the tibia. And the HKA can be variable. We don't know what will be the HKA. It will be based on what is the pre-arthritic alignment for the patient. Restricted kinematic, there are boundaries, plus or minus 5 coronal, plus or minus 3 overall. Native laxity pattern is attempted, that is in flexion, the lateral side is left lax. Extension, it will be balanced on medial and lateral side. Adjustments again are made on the tibia. HK 177 to 183, plus or minus 3 is the accepted. For functional, again boundaries are restricted, they can be narrow or wide. You have a balanced extension and flexion gap. And you can make adjustments both on tibia or femur. And the overall HKA based on literature is 6 degree varus to 3 degree valgus. So this is the consensus of the robotic fraternity to start with. So you definitely need technology to get these sort of dynamic balancing and subtle changes in the coronal plane and sagittal plane. So it is definitely a technology based system. And if you compare kinematic and restricted kinematic and versus functional, functional is more balance driven. So it can balance the knee both in extension and flexion, but it will accept whatever is the residual alignment within some boundaries. For kinematic and restricted kinematic, they accept some amount of laxity on the lateral side in flexion. So that's the difference between functional and kinematic philosophies. So what we need to do, we have to define the key concepts. Where is the starting point? Is it a mechanical start point or is it a kinematic start point? Or where is the end point? And what are the boundaries of implant position and what are the final gaps and laxity patterns? These 4 things we have to see whenever we are doing the robotic technique. And this particular paper by Gavin Clark has given some credence to this particular thought process. The forgotten joint. They said you must calibrate the joint line obliquity and the CPAC type, and wherever possible, try and restore the patient to the native joint line obliquity and CPAC without compromising on the overall boundaries which are present in the thing. So there is some value to the thought process, but this is just one paper, and this again has shown that functional alignment probably is the way forward because you need to balance your knee because the polyethylene needs to be loaded uniformly and the implant bone interface stresses need to be distributed uniformly. So if you are accepting an alignment of 5 degree varus and you are not balancing the knee, then it would be a disaster. So that is what this particular paper from Sebastian Lustig found, that the kinematic alignment as compared to functional alignment did not achieve balancing in more than 50% of varus knees, while functional alignment could achieve the balancing. So functional alignment is a reasonable compromise between whatever all we have today. It's a balance-driven strategy with emphasis on recreating the joint line obliquity. So you need to have a kinematic start point for this, and the kinematic start point maintains the joint line obliquity, and this has been shown to provide better forgotten joint scores in the long run, and given better patient-reported outcome measures. So finally, know what alignment you want to achieve. If you are using robotics, what is the start point, mechanical or kinematic? What are the implant boundaries? What are the laxity end points? And you must define the sagittal and rotational boundaries for your own self in your individual practice. Thank you.
Thanks, Dr. Krishnakan. It's a well said. There are 17 alignments are there. So you know that the 17 alignments are there. What Rajkumar said, the gold standard is till today is a mechanical alignment. If you have technology, you can have the functional alignments. What can just fix the boundaries, keep the bone, not to overdo 5 degree, whereas sometimes I'll give accelerators of 7 degrees. No, that's not possible. Fix the boundaries, 2 here, 2 there. Within 5 you can play around. So software should be very minimal. So what's Rajkumar's take on alignment?
Definitely alignment is the need of the hour because we cannot keep telling conventional is the gold standard. Yes, it is gold standard, but we know whatever X-rays I showed, 16 years follow-up, 14 years follow-up is all radiological. Okay, so it is all patient's implant is surviving. Whether the patient was not really technology, we have to juggle out and say, okay, this is my boundary, and I do here and see cautiously whether that is going to give survivorship and functionally good result. That is where the balance of functional alignment. Even if I have to go for an alignment, I will select something related to functional, not pure